And that leads nicely on to our next question is, and we've been tempted by thinking that everyone should have Paris Olympic quality point of care testing. Is that really going to make the difference? So it's a great pleasure, Dr. Katherine Bond, infectious disease physician, looking at some new diagnostics and COVID infections and maybe where point of care should be, even if it's not. Thank you.
Thank you very much. Thank you, and thanks very much to the organising committee and Lou for having me here. I feel a little bit like an odd speaker out amongst such depth of expertise and leadership here, but I have supervised a lot of respiratory testing in the last few years. So let me just work this one out. No. Sorry. No. Yeah. Yeah. All right, we're ready. So I am speaking today about antigen testing really and PCR. And I am going to spend a little bit of time on the fundamentals, so I hope I don't bore you too much, but I think that does really inform the clinical utility, because I think they're both here to stay, and I think there's not a good and a bad test, and there's just when you should use one or the other. So I guess some of this is directed more at those people who are requesting tests and interpreting tests, always thinking about, well, what am I trying to achieve by doing the test? Am I trying to make a diagnosis? And is it a diagnosis for the thing that presented today, last week, or last month? Or am I just trying to work out, get a measure of how infectious they're likely to be? And what's the consequence of making or not making the diagnosis? Am I going to prescribe something? Am I looking to isolate to clear them? Or am I just trying to identify someone who might be at higher risk and needs some escalation of care? And so can I afford to miss the diagnosis in this individual is often the question you need to ask. Are there particular risk factors for why you wouldn't want to miss that diagnosis? And what is my setting? How many diagnoses do I need to make today? And then obviously you're going to consider these other aspects of usability, cost and resources. So it's coming. So a little bit just on the virus itself, because I think our tests, we often ask a lot of our tests, and I think understanding what's happening with the virus it helps to understand some of the limitations in the test. So when you're first infected, particularly in the respiratory epithelium, it's the RNA that rises first and then the antigen follows. And so you tests that are looking at RNA are always going to be sensitive more quickly because the RNA is there and the antigen or the protein is not. Our host immune system has a dedicated system to recognise the antigen with antibody antigen complexes being formed, and so they're quite quickly cleared from the system as well. So your proteins are going to be there at the time of infection and in time of infectiousness, whereas there's not really a dedicated system to clear RNA from the body. So that's why you get this long tail with the RNA being positive quite a long way into the post-infectious or convalescent period. I think people are familiar somewhat with the lateral flows. I'm just going to talk about respiratory lateral flows today. We did mention earlier this morning about urinary lateral flows for really Streptococcus and Legionella, but I'm just going to focus on the respiratory ones today. The sample is placed on a sample pad. It then binds to a conjugated antibody, which travels up the membrane and then is captured on a specific test line that recognises those specific antigens. And then whatever's not bound there washes over onto the control line. So the nitrocellulose membrane is actually quite an important step in that the liquid needs to travel slowly enough along that strip to allow the binding to happen, but also not too slowly such that you get non-specific binding. So the strip and the buffer are actually quite important, and mixing and matching between kits is when you'll get some non-specific results. And these are also the aspects to consider when we think about newer generation antigen testing, and these are the aspects we can improve upon. So So the binding of the nanoparticles to the antigen, so different compounds of nanoparticles and the size of nanoparticles is important. And then also thinking about that test line, is there anything, at the moment we detect that via visual cue, but what can we do to increase the sensitivity by having more sensitive detection methods? If you start to move to specific sort of fluorescent methods and with the little readers, they can be improve your sensitivity, but then you lose some of that usability by needing to have this special reading device. And another sort of concept to think about is this sensitivity and specificity are widely reported to describe the performance of assays, and just to be aware that there's a clinical sensitivity in that this patient presents with respiratory symptoms and what's the likelihood that this test is going to diagnose their syndrome. But that's a little bit hard. You're asking a lot of the test if there's no antigen in that sample. You're asking a bit much for that test to become positive. So then we talk about an analytical sensitivity, which we really use to compare the quality of different tests against each other, because at least the antigen's in there. So is the test able to find the antigen that's in there or not? And so the aspects of these lateral antigen detection tests which affect that analytical sensitivity at the moment compared to PCR, it's a non-amplification assay, so you need a reasonable amount of protein there to bind to the antibody, and then we're just using these less sensitive visual cues for detection. In terms of specificity, we've said that it correlates best to infectious syndrome, but it's not going to diagnose your infection from last week. And analytical are really made up by the people who make the assays, so the buffer they choose, the concentration of reagents. And so they're very specific in that antigens don't cross-react with other viruses. So if it's telling you you've got COVID, you're not going to have RSV. But other substances can react with the test strip, as lots of UK students learnt. If you add a little bit of orange juice to the sample buffer, it gives you a positive test line. So there are some common sense aspects to using the test. PCR, I think everyone's pretty familiar, but that's an amplification. So just tiny minute amount of RNA is going to be detected. We have super specialised and sensitive methods to detect those small changes in fluorescence. And I think cycle threshold is a concept which in the hospital setting everyone became a lot more familiar with, which is a semi-quantitative measure of how much RNA is in that sample. So the quicker the sampled, the more sample in there, the quicker it will take to fluoresce, and so the less cycles of PCR you need. This was used as a surrogate for infectiousness in the hospital prior to antigen use and still today. So it's always going to be more sensitive from a clinical and an analytical point of view, because we've said the RNA gets there first, and we've got these special assay design features which make it much more sensitive. However, it's less specific for current infection. With all the sort of with the current assays, they're really very specific. So there's very little cross-reaction that happens these days. So this is why they're really the gold standard for our viral pathogen detection. And so this is my attempt to sort of summarise that for you. Excuse my graph, but. So we've said that you're going to have less false negative, PCRs early. You're going to have a higher lag time for the antigen assays early, and so that's on average about 2 days. And then there is a little bit of a false negative antigen period post your acute infection, just before you become non-infectious, if we're comparing viral antigen assays to viral culture, but a much longer period of false positive if you're using your PCR to diagnose acute infection. And the limit of detection is significantly different. So PCR, we're down to 20 or 30 copies versus 10 to the 5, 10 to the 6 for the lateral flow. And that's about the same level of detection in viral culture studies, around 10 to the 6. You'll get sort of 5% maybe that will be culturable, down to 10 to the 3, 10 to the 4. So if you've got a positive antigen test, 95 to 100% of them will be culture positive and infectious. If you get a negative antigen test, about 10% of those will be still culture positive, and that's more likely early in infection. And in worker surveys where they were getting screening antigen tests sort of daily or second daily, you will miss a few transmissions in that early period, which can be mitigated by some of the increased frequency and use. Whereas it's been estimated that about 50% of the time that someone's PCR positive, they might actually be in their post-infectious period. And there are certain host cohorts that are more likely to be have this prolonged post-infectious phase. So we all know antigen test assays are much more usable, user-friendly, they're rapid, they're cheap. Unfortunately, at the moment, there's not really a funding system in place for them under unusual pathology sort of accreditation, so there's no remuneration for doing the test. We know that self-tests are comparable to healthcare worker tests, so you're not really getting an advantage in having a healthcare worker take the sample. Community surveys have shown a high degree of acceptability. People are happy to do the tests, and there's just some figures from the UK there. We can see once lateral flow assays became available, they outstripped PCRs in terms of the frequency of use. There are some caveats to how they're handled, but really they're pretty robust. But one of the main limitations is getting that data, translating that into actionable results. We know that people will have behaviour change just by doing the test themselves and seeing the result, but you get more bang for your buck in terms of impact of that test if we can transmit that result to downstream actions, whether they be just surveillance versus linking into care for treatment. And in the UK, a minority of lateral flow assay results were reported back to the overarching public health system. PCR, on the other hand, we've heard a little bit about point of care tests, so they're the ones down at 45 minutes. You've got the other ones that are manual, sort of two-step assays where you're doing a separate extraction and amplification, and that requires a person to move that test along the pathway. And so hands-on time, that's 6 hours, but if you're going to do that once a day, that's obviously potentially 30 hours or 24 hours. The cost is not too bad. I put $25 to $50 there, but I mean the BioFire that we've been speaking about this morning, that cost my lab $230 to buy. So in terms of the $50 ones would be the manual ones that are, have a separate two-step system, or only maybe 4 targets. But there is this cost recovery model for it, so we have systems in place to manage that. And they're very robust. The reports are really reliable, but you obviously need that quality and laboratory framework around them to ensure that the results stay reliable, and they integrate with all of our current systems. So we get maximum benefit from getting a result for that patient. So this is pretty hard to do because, for a few reasons, a lot of dodgy assays came on the market initially that I think are off the market now. We often initially asked our antigen tests to do a lot and perhaps use them in clinical settings that weren't quite appropriate. But in general, the good ones are pretty good, 70 to 80% sensitive in symptomatic patients, less so in asymptomatic patients. If you've got a lot of virus in the nasopharynx, then the sensitivity is over 90%, and then obviously drops off if you don't have as much. Specificity is really good. So if you get a positive test, you're more than likely to have that condition, and there's really only a handful of false positives we see. However, it is still slightly less specific than PCR, so you get a few more. It will cross-react if SARS ever comes back. But I've mentioned this high variability in the quality of tests, and it's very hard as an end user to know which test is reliable and which one should I choose to use. So WHO has some quality standards that they expect or recommend for these antigen assays, but in sort of middle pandemic or late pandemic, actually only 8 of the 200 assays on the market at that point met those targets. There's more than 1,000 assays on the market now, and there's not really a central body that is governing their quality in terms of getting registration. And even in those patients with lots of viral load, only 10% of assays had the required sensitivity in the UK in another assay, another study, sorry. So I think part of the problem is that there's poor standardisation as to how we calculate the limit of detection. And the limit of detection is how in the lab we'd say, right, well, this assay is going to detect more protein than this assay for any given amount of protein in a sample. And there's no right or wrong way to do that, and there's some convention. And I think initially and in the instructions for use and the data that a lot of the manufacturers report to the FDA or the TGA, they've used a tissue culture infectious dose kind of limit. And that's where you infect a cell line, you wait for the virus to infect the cells, you look for cytopathic effect, and then you work out at what point 50% of the cells are infected. But these assays are detecting nucleocapsid protein, and that's only evident when the cells are lysed. So they detect the free nucleocapsid protein. So the TCID 50, they're cells that are, some of them are still intact, some of them are lysed, and so that number correlates quite poorly to what the actual amount of free nucleocapsid is. So this was a study that looked at a number of assays on the market at the moment. They actually used a purified nucleocapsid protein and a dilution series and then tested them all. So you can see, for starters in panel A that there are about 6 assays at the top that were sensitive down to a level of 0.05. So they're sort of 20 times more sensitive, if you like, than the 20 assays below them. They actually used an image capture software here and normalised the visual band, so it's pretty robust. It wasn't, there's not inter-operator variability contributing here. And I think part of, as much as, it's great, okay, this assay is going to detect a lower amount of antigen, so that's good in and of itself, but it also means that at any other concentration, the intensity of that band is stronger. So actually it's easier to use at all those concentrations because the band's easier to see. So I think that there's a couple of benefits there. And then, sorry, my formatting's not great there, but you can see that according to manufacturers' limits that are mentioned in their kit insert, that on the lower level they've all reported to have the same TCID, so if you were trying to choose an assay they'd all look the same, but actually there's quite a difference if you're looking at the nuclear protein sensitivity by that method. So I think we just need to standardise. Whoa, sorry. All right, we'll just skip that. So I think standardisation is still to come and needs to be improved further. So what did we learn about their use in a pandemic setting? We learned that frequency of testing is more important than sensitivity of the test assay. And really, if you had test delays more than 2 or 3 days, you weren't able to get the R less than 1, so you weren't going to reduce your number of cases. And I think even we were very fortunate in my hospital setting to have point-of-care testing available, run through the laboratory, but our median turnaround time for a COVID test for all of our presenting patients at the height of the epidemic in Melbourne was still 2.5 hours. But when we rolled out lateral flow assays, and this was before they were licensed, so we were doing them both in parallel, we still managed to move patients out of the ED significantly earlier. So even with such a small difference, really, we know some people were waiting days for tests in the community, but by reducing it from a 2.5 hour turnaround time to a 20-30 minute turnaround time, our length of stay for those patients was reduced by 2 hours, and anyone who works in the hospital knows that ED length of stay is really important. So modelling suggests that if you do mass testing, you're likely to detect about 80 or 90% of infectious cases, and that's usually more cost effective and per life saved than PCR strategy. And that's most impact when the prevalence is high, the case numbers are rising, and there's some added pressure to test, and you're going to be isolated if you don't. And that was shown to be successful at population levels. Slovakia tested about 2/3 of their population, and following that they managed to reduce their infectious case numbers by about 60%. So in general, the European guidelines weekly favour antigen testing versus PCR. One thing to be aware of is that, unfortunately, like many other aspects of the COVID pandemic, there was inequitable access to lateral flows. Essentially, wealthier countries bought them all up. And so you can see that map there of where antigen testing was available and not available. Just quickly on multiplex testing, it's just really starting to, antigen testing, it's just coming out now, mostly SARS, flu and RSV. There's variable sensitivity for the different targets, and just looking at one assay there, you can see for SARS it's 80%, flu 60% and flu B is 45%. And that's really true of most of the assays that are coming out. There's that differential sensitivity. And there are similar guidelines that the TGA has around that. One study prospectively testing in an ED and urgent care for kids showed that about half of their presentations with ILI bronchiolitis or otitis media turned up a positive result. So I think there will be utility for these tests in that kind of setting, but particularly with paediatric population. All right, so I am coming to the end of my time, so I'll whiz through. I've talked a little bit about the importance of standardisation. There are lots of updates with respect to trying to tweak the assays and how we detect and don't detect that will improve sensitivity, but we just have to think about what the offset is for usability, and often if you make something more sensitive, you make it less specific. So we don't want to get to a point where they're okay sensitivity and okay specificity. I think the situation we've got where we know that if it's positive, it's a great rule-in test is more clinically useful. Quantitation will come, and there are improved apps and AI deep learning systems and digital care pathways to be able to integrate these results. Just to, I guess, in light of the discussion we had this morning about multiplex testing and BioFire and availability, I just pulled our numbers on the multiplex testing, and it's going up and up and up each quarter. And so this is in a hospital setting. So is this due to that increased awareness of the morbidity associated with all respiratory viruses? Is the increased availability tapping into populations that we weren't testing before, so asymptomatic screening before transplants and things like that? Or is there just some decreased tolerance for diagnostic uncertainty? But I think we don't yet know whether we're definitely benefiting from this increase or not. I think we need to do the studies to work out whether we are. And Lou pointed out that you can get multiple positive results, and what do they mean? The screen on the left is what you'll see, the screen on the right is what I'll see. And I don't think quantitative PCR is the answer, because that requires a lot of extra controls and faffing around when the exact number is not important. But I think the general vibe can be quite helpful, and I think there is a role for semi-quantitative reporting of these assays. All right. I'll finish there with respiratory metagenomics, just to say that it's all going to get a lot harder because now we're going to look for everything in the sample, and that'll raise more and more of these questions. Thank you.
Thank you. Thank you very much. We're going to have a panel discussion later. So, but just one question I got online that sort of comes together: the stability when you want to use them in the country and transporting them. So, are they sort of stable? And then the other question: are they useful to determine whether antivirals should be used?
Yeah, so they're pretty robust, and up to temperatures sort of 35 and 40, you're okay. I mean, if you're really getting up, above 60 degrees, then that's probably going to affect the stability. And there were some studies in Africa that did show some slightly reduced rates in sensitivity in particular. And as I've said, they're a really great rule-in test. So if it's positive, you are okay to start antivirals, and start treatment.
Okay, thank you.